पूरा लाइव चल रहा है।
Your group first group second.
Today is the opportunity to build the tomorrow you want. With this quote, I, Miss Aishwarya Hirimat, welcome you all to the AICT sponsored Virtual Quality Improvement Program theme, Emerging Trends in Clinical Research and Development. Let's begin this program with a beautiful invocation song by Miss Darshini Shetty. शुभ गुणदायक शुभ वरदायक शुभ गुणदायक शुभ वरदायक भोगणनायक नमोस्तुते भोगणनायक नमोस्तुते शुभ सुखदायक शुभ फलदायक शुभ सुखदायक शुभ फलदायक सिद्धि विनायक नमोस्तुते सिद्धि विनायक नमोस्तुते शुभ गुणदायक शुभ वरदायक भोगणनायक नमोस्तुते अम्बासुतवरलम्बोदरा अम्बासुतवरलम्बोदरा चिरसौख्य विनायक नमोस्तुते चिरसौख्य विनायक नमोस्तुते करिमुखाशित सुगान् सुदोषित करिमुखाशित सुगान् सुदोषित प्रमथ विनायक नमोस्तुते सिद्धि विनायक नमोस्तुते शुभ गुणदायक शुभ वरदायक शुभ गुणदायक शुभ वरदायक भोगणनायक नमोस्तुते शुभ सुखदायक शुभ फलदायक शुभ सुखदायक शुभ फलदायक सिद्धि विनायक नमोस्तुते सिद्धि विनायक नमोस्तुते शुभ गुणदायक शुभ वरदायक भोगणनायक नमोस्तुते भोगणनायक 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 नमोस्तुते. Thank you, Darshini. Now I request MS Ganachari Sir, HOD, Department of Pharmacy Practice, Deputy Registrar of CAHIR, Dean Faculty of Pharmacy, to give us a brief program overview.
Good morning, everyone. Respected Chief Guest of the today's program, Dr. Rajesh Pawar, Vice Principal of very prestigious Constituent of CAHIR Jain Medical College and Plastic Surgeon by profession. Respected Vice Principal, Dr. M.B. Patil, sir. Respected Principal, Dr. Sunil Jalalpure has been assigned with some important assignments, so he could not be the part of this inaugural program. Senior teacher and my mentor, Dr. B.M. Patil, sir. All colleagues from different departments. Special note colleagues from my department, ladies and gentlemen. It is a privilege to be the part of this, a flagship program of KLE College of Pharmacy, Belagavi, in general and particular for Department of Pharmacy Practice. AICT sponsored Quality Improvement Program on the theme Emerging Trends in Clinical Research and Development. which has been funded, supported by All India Council for Technical Education. As we all know this QIP is a very popular program, and we were the first in the to start this program in the first batch when the AICTE identifies as the QIP centers across the state, and probably we are the one or two amongst the private institutions to get this QIP cell in Belagavi. Of course, the credit should go to the then Vice Chancellor of our university, Dr. C.K. Kokate sir, who made a lot of efforts, saying that we were one of the best colleges to get this opportunity to host the QIP program. Since then, probably nearly 2 decades, we are conducting this program for the contribution to the training of the teachers, particularly the young teachers who has got less than 10 years, abreasting them with the changing things that is happening in the field of pharmacy, depending upon the different thrust areas, and so on and so forth. The continuation of this QIP program, every year we conduct 2 weeks program for 3 times in a year. And in the last NAC, it was well appreciated, saying that we have got huge statistics, how many people are trained and so on and so forth. And one of the criteria which has been carried or sailed us throughout all our credentials of the university may be NBA accredited for 6 years duration. And recently we got an A+ by NAC, securing a good CGPA, or else may it be the other credentials being the top 50 in the NRF ranking and all those things. KLE College of Pharmacy, having the legacy of more than 54 years of quality pharmacy education in this part of Karnataka, hails saying that we are one of the best institution in terms of imparting the quality educations. We do get students across the country. We do have a couple of international collaborations, as well as we are going to have a very high impact factor publication as research is concerned. Coming to the Department of Pharmacy Practice, which we are the host for today's QIP program, we are always blessed with one of the state-of-art 2,400 Dr. Prabhakar Kore Hospital Medical and Research Center. Not only that, with good, able guidance, mentorship and support from all the faculties of Jain Medical College, the Principal of Medical College, Dr. Manshetty ma'am, Vice Principal, Dr. Rajesh Pawar, Dr. Patan Shetty sir, and even Medical Director, Dr. Jali, all were the supporting for us to start this program of this pharmacy practice. Because this pharmacy practice is a department where we are working with the hospital, with the healthcare team members, supporting, strengthening for the better patient care. Apart from the hospital, we are able to establish certain services in the hospital for the benefit of the people who have joined. Apart from training our pharmacy practice students, we are doing a small contribution to the patients in terms of patient education, patient counseling, and more remarkably, my department and colleagues are working enormously for the clinical research and clinical trials. We are running not less than nearly more than 100 clinical trials, active clinical trials from almost all noted CROs and multinational companies. The advantage for my department, it becomes a live laboratory for training of students and getting truly the industry institution interaction and getting closer towards the industries. Apart from those things, my department is a part of the ethics committee approved and recognized by DCGI, Drug Control General of India of CSCO, and it has been accredited by the 2 noted accrediting agency, NABH as well as the FERCAP. Apart from those things, for the information of our guests today, sir, we have started the reconstitution of cytotoxic drug. Professionally, we have started, and right now one full-time faculty has been posted in hemato-oncology and pediatrics. We are rendering the services to do professionally reconstitution of cytotoxic drug, the taking the orders, packing, dispensing, and monitoring when the drug has been administered. And subsequently, we want to start the services of this total parental nutrition. Already we are working on that. Probably in upcoming months, we are going to start the parental nutrition. These are a couple of things probably we can boast or we can bank upon that we are doing good and we are getting a lot of credentials in terms of professionally. One is a clinical research. Second is a reconstitution cytotoxic drug, reconstitution total parental nutrition. And recently we have got a ADR monitoring center and we are also working towards train our students in pharmacovigilance. So this is something, a background of our institution of QIP and the activities of my department. At the outset, I would like to thank the today's chief guest, Dr. Rajesh Pawar sir. You all know that he's a very busy surgeon, plastic surgeon. When we requested, sir readily accepted. Sir, thanks for accepting our invitation. And I heard that in the morning, he completed one surgery and straight we walked into our this one. Thank you, sir, for accepting our invitation and witnessing this inaugural program. My greetings are from Principal Dr. Sunil Jalalpure. He wished to be here today, but he has got some other assignment of the larger assignment from our sponsoring society. So he's expressed his leave of absentia for this inaugural program. I should have to acknowledge him for his all timely support for successful conduct of this program. All the time, Dr. M.B. Patil sir, Vice Principal, he's always there silently, monitoring, silently, supporting, guiding, sometimes violently on the students. Maintaining the discipline in the way of what I'm telling. That is how we can see that where is managing the entire college of having more than 800 students on the campus exclusively for the pharmacy college. So thank you for all your supports and the guidances for this conduct this program. A very senior teacher, Dr. B.M. Patil sir, very active researcher. By default or by compulsion, he was a administrator for all the time. After his tenure as a principal, he started pursuing his career as a researcher. Basically, he is known as a researcher and has contributed a good number of publications. Sir, thank you and being the part of this inaugural program. Of course, I would like to appreciate all my colleagues from all the departments who have worked very hard for the all credentials and accolades what we have got it and supporting my department, because we have got little different challenges as a pharmacy practice department is there. I thank one and all and I appreciate. Last words for my young department, young colleagues in my department. Particularly for today's program, I feel that good time for me to retire as a head of the department for simple reason, because everything that I've done, sir, just I walked into this room, even yesterday I didn't come, they're so much well trained, so much confident, saying that they can do on their own. I appreciate the department. They're meticulously conducted this program. Thank you all my colleagues. With this brief welcome and program, I'll just quickly go through the overview of the program for the benefit of the participants for next 1 week where they're supposed to participate. As per the QIP, there is a few words for the participants who have joined online or virtually. This is a very pious program what we conduct every year religiously. We have got a lot of values for the program, a lot of significance for the program. Already we have circulated the SOPs for the entire program, saying that who all are eligible for what are we going to supposed to do it, because it is a funded program and we are accountable for that. Keeping the title as a trends in clinical research, we have invited the people from industries, from academics and all the programs so that it becomes a 360-degree understanding of the clinical research and clear development. And particularly it is good for our young teachers from different departments because it's been integral part of the diploma syllabus also. The new diploma syllabus has got some component of clinical research and clinical trials. We have got to call the people from different industries. We have got one speaker from senior medical writer from IQA will be introducing when the session goes up, and we have got a senior professor of pharmacology we are invited. Then we have got a person, the speaker from PPD Pharmaceuticals is a clinical research associate 2 and a senior country approval specialist. We have got a central monitor for clinical trials from IQA Bangalore. We have got We have got I request the member, the people who are joined to mute yourself. Then we have got a couple of physicians, very senior physicians from our university. We have got another speaker from Manager Safety and Pharmacovigilance from Syneos Pune, Associate Case Manager from Ililala Bangalore, and we have got a statistician also we invited. And subsequently, we have got one more speaker from CBC Global Research at Ahmedabad, and remaining my colleagues are going to engage the sessions for next 1 week. This is the overview for QIP program. With this, I welcome one and all for this inaugural program. We are joined virtually as well as physically to all my students and all my colleagues. Thank you one and all.
Thank you, sir. Now I request Mrs. Geetanjali Salimat ma'am, Assistant Professor, Department of Pharmacy Practice, to introduce our chief guest.
Thank you, Aishwarya. I welcome you all for this AICT sponsored QIP program. Among us, we have person of magnification, Dr. Rajesh S. Pawar, sir. So I take this privilege to introduce you, sir. Sir is at present Vice Principal, Jain Medical College, Belagavi. He is also Professor and Head, Department of Plastic and Reconstructive Surgery. Sir was born in 1968. He has completed his MBBS from Jain Medical College, Belagavi, MS from Government Medical College, Miraj, MCH Plastic Surgery, Grant Medical College, Mumbai, DNB Plastic Surgery, National Board of Examination, New Delhi. Sir has, to his credit, vast experience of 30 years in Jain Medical College. He served as Assistant Professor, Associate Professor, and at present working as Professor and HOD. Sir has area of interest in cleft and craniofacial surgery, cosmetic surgery. Sir has more than 20 publications at different platforms. To his credit, Sir has many achievements. To name few, he is leading the KLE Smile Train project, under which almost 1,000 surgeries have been performed. Started the Department of Plastic and Reconstructive Surgery at JNMC. Best outgoing student of the JNMC for the year 1990. Sir, he takes personalized approach with up-to-date treatment options to optimize the outcome. He believes in making sure that each patient is benefited with newer approaches and take home a pleasant experience with a smile on his face. He is persona of magnification with healing touch and smile in millions, touching their hearts. Sir, we wish happiness and success in all your future endeavors. We are very fortunate to have you today with us. Welcome once again, sir.
Thank you, ma'am. Now I request Professor Dr. M.S. Ganachari, sir, to present sampling to our chief guest, Dr. Rajesh Pawar, sir. I request Professor Dr. M.S. Ganachari, sir, to present sampling to our Professor Dr. M.B. Patil, sir. I request Dr. Ramesh Mandari, sir, to present sampling to our Head of Department, Dr. M.S. Ganachari, sir. Now I request Dr. Satish Karoli, sir, to present sampling to our BM Patil, sir. Now I request all the dignitaries to come forward for the lighting of the lamp.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय
Aishwarya. Before you proceed, I would like to wish many, many happy returns of the day for our Vice Principal, Dr. M.B. Patil, sir. Today is his birthday. I wish we should have brought a cake also, but just now we came to know that. Anyway, sir, happy birthday for today's this one. Thank you. Yeah, go ahead.
I request our chief guest, Dr. Rajesh Pawar, sir, Vice Principal, JNMC, Belagavi, to address the gathering.
Respected Professor Ganachari, B.M. Patil sir, M.B. Patil sir, all the faculty of this prestigious College of Pharmacy, Belgavi, delegates who have joined online here, as well as those who are present here, and all the other faculty who will be contributing to this prestigious initiative of this college, I mean, which is sponsored by AICTE. It is indeed a great honor for me to be present amongst you all and be the chief guest for such a wonderful function. I would like to take this opportunity to once again wish M.B. Patil sir a very happy birthday. As I said, this sorts of initiative, quality improvement initiatives are very much essential in any institution, be it academic or otherwise. And this very well thought of program on emerging trends in clinical research and development is the need of the hour. And I just went through the program, and each talk, each session of the program is so very well planned, right from the basics of clinical research to the advanced recent trends which are upcoming. Though I am from the medical background, I still feel that the keystone for any new investigational drug study, the keystone is the pharmacist. It's just a matter of time wherein a pharmacist starts leading the team of clinical research into even active research, whatever the stage of trial, the contribution of the pharmacist is the ultimate, be it right from the conception as the researcher, implementation of the trial, the assessment of the trial as the analyst, or even after that as a person who is going to decide on the marketing strategy. So this is what I feel is the need of the hour and what is going to be the future. Now these days, I mean, what has been planned here is so relevant, and the timing is so perfect. We all know, I mean, in the 90s, how India was considered to be a hub for clinical trial, but somehow that was in a very negative image that India had because of the very lax regulatory policies. We had seen a lot of people coming into India to try conduct clinical trials, and we all know how our people suffered and how we were taken for granted. But from that stage to today, the way we have progressed, and we are going to be the leaders eventually in clinical trials, and that's a matter of real pride for us. And this time is exactly when we need to take initiatives in conducting programs on clinical trials and development, research and development. Today we see a lot of sea change that has occurred now. Firstly, the pandemic situation that has occurred, and we have seen that so many drug trials abroad elsewhere have been stalled. In fact, I believe more than 86% of the trials in the US, they don't have enough recruitments for conducting the trials. So we are there here to provide that sort of a support in India. Even the pandemic has seen so many newer things coming up, especially trials in vaccinations and things like that. So we have to take this opportunity to come up and take the leverage from the present situation and emerge as leaders in clinical trial. This present situation in Europe, what we are seeing, the Ukrainian crisis that we see, or for that matter, even the Brexit, all these things are going to reflect on the clinical trials in the European countries. And we are going to be there to take the burden, and I wouldn't rightly put it as burden, but the opportunity we would like to see that as an opportunity to emerge as leaders in clinical trials. Recently, we are seeing changes in the clinical trials, and in the future, we are going to see so many newer things. I mean, the digital transformation has made remote access possible. We are being able to conduct trials remotely, and that is going to be another advantage for us. Our IT industry is strong. We have a strong backing of the software industry, and that is going to be another boon for us. Rest of the country, if you look at the rest of the world, if you consider now, the China is there, but then they have certain barriers. The transparency which is there in India is not there in China. The political situation is different. The language barrier is there. So we have a definite advantage to take over this opportunity. One thing I would like to highlight here is that personalized medicine is the future which is going to come up. So what we need to think about is the genetic profile of the participants that we are enrolling into the studies, and that is going to be the thing of future. So that way we have to think of this future and think in the way we are heading this clinical research and development. We have to keep it in mind that genetics is going to be an integral part of clinical research and development in the future. And we have to, I think, we have to think of this and start developing our resources and the way we think in the teaching, or for that matter, training of our younger teachers. We should try to incorporate this in our training of the younger pharmacist. Well, I am a part of various clinical trials, but the way a pharmacist approaches clinical trials is way different from a clinician. A clinician has so many other responsibilities. The way the priorities are never to the clinical research and clinical trials. But for a pharmacist, it can be the main thing, and they can start spearheading these teams of clinical trials and clinical research, and they are here to stay. And I think the baton of the entire thing has to be taken over by the pharmacist. As Professor Ganachari rightly said, I mean, we are seeing so much of contribution in our healthcare from the pharmacy, College of Pharmacy, be it pharmacovigilance, the ADR section which is coming up, the D-Pharma students being posted in our college and being part of the therapeutics and treatment planning of the patients is the future that we are seeing. I'm so happy that our college, the College of Pharmacy, one of the top colleges in the country, And I'm sure it's there to grow, and in the near future, we are going to see it progress even further. Is going to take this advantage of a college being so closely associated with it in trying to catapult its growth into one of the top colleges, top 10 colleges in the country. We are all there to support any initiative from your side which requires support from the medical college. We are more than happy to be part of it. In fact, we would like to encourage you all, or even coerce you all to be a part of our healthcare. I mean, patient care, which translates into the patient care. With these few words, I once again I should especially thank Gitanjali madam for that wonderful introduction that she gave. Thanks a lot, ma'am. I mean, whatever we try to do, we try to do. The only thing I would like to put forth is whatever you do, whether it is for your patient care or research, whatever commitment of us, be it personal or professional, has to be with passion. And whatever we do, when the passion is there, excellence eventually follows. With those few words, I would once again like to thank the College of Pharmacy, especially Professor Ganachari and Dr. Jalapure for inviting me for this wonderful function. I wish this program all the best, and I'm sure it is going to fulfill all the objectives that it is aimed at achieving. Thank you. Thanks a lot.
Thank you. Thank you, sir, for encouraging us. Now I request our beloved Vice Principal, sir, Professor Dr. M.B. Patil, sir, to give presidential remarks.
Good morning, everyone. Greetings of the day. Myself and on behalf of Principal Sir, Dr. S.S. Jalalpure, KLE College of Pharmacy, take the pleasure to orate presidential remarks on the AICT sponsored quality improvement program being conducted by Department of Pharmacy Practice. First of all, I heartily welcome today's chief guest, Dr. Rajesh S. Pawar, Vice Principal, JNMC Belgavi, who is also Professor and Head Department of Plastic and Reconstructive Surgery. He is one of the renowned cosmetic surgeon in India. Welcome you, sir. I thank Dr. M.S. Ganachari, HOD, Pharmacy Practice and Deputy Registrar, Kaher, and Dean Faculty of Pharmacy and Faculty of Department of Pharmacy Practice for inviting me on this occasion. We, the family of KLE Academy of Higher Education and Research, accredited with A+ grade by NAC, feel privileged to welcome you all to be part of this program, which is a true reflection of the quality improvement for the professional growth and raising the benchmark of skills. The topic is very appropriate as it focuses on emerging trends in clinical research and development. It is about improving the patient safety and quality of care through research development stages. It is a considerable effort from the Department of Pharmacy Practice in choosing such an appropriate topic. I request you all to utilize this unique opportunity. Before concluding, I once again thank Dr. M.S. Ganachari and Faculty of Pharmacy Practice for inviting for this quality improvement program. Thank you.
Thank you, sir. Now I request Mrs. Shashikala Wali, ma'am, Associate Professor, Department of Pharmacy Practice, to propose vote of thanks.
Once again, very good morning to one and all. It gives me an immense pleasure to propose a vote of thanks. I, and on behalf of Department of Pharmacy Practice and KLE College of Pharmacy and AICT sponsored QIP, I would like to thank today's chief guest, Dr. Rajesh Pawar, sir. Accepting our invitation during your busy schedule, sir, and gracing the occasion. Once again, thank you so much, sir. I would like to thank our beloved principal, sir, Sunil Jalalpure, sir, his support for conducting of this program. I also thank our college vice principal, sir, Dr. M.B. Patil, sir, attending this inauguration. Thank you so much, sir, and wish you happy birthday and wish you happy wedding anniversary also, sir. I also thank our head of the department and deputy registrar of Kaher, dean of faculty pharmacy, Dr. M.S. Ganachari, sir. Always gives us support and motivation for conduct of this program. Thank you so much, sir. I also thank former principal, sir, Dr. B.M. Patil, sir. Thank you so much for attending the inauguration function. So I thank dear participants and colleagues and senior professors, dear students attending this inauguration function online and offline mode. I thank you one and all.
Thank you, everyone. So now we'll have a short break. Tea will be served outside. So all of you have to come back exactly at 10:30. The session begins immediately at 10:30.
Dear participants, shortly we are going to send you the pre-test questionnaires. So please fill the answers for the questionnaires. Then we will start the session. So 10 minutes will be given for the durations. Thank you.
Hello, dear participants, can you see your quiz on your screen?
Nadeep.
Okay, okay. Yes.
वो बंद करो. You go to the poll down. इसको exit करो.
No, sir, they are filling.
Yes.
Maybe.
अच्छा, that you're showing the progress. Good morning. Hope all the audience, am I audible to you? Anyone can unmute yourself and tell.
Yes, sir, you are audible.
All right, thank you. I request all the people who have joined, please complete the pre-test quiz, which is available on the Zoom window at the bottom, which is called as a polls. You click the button polls, right? You'll get a questions. You can, they're simple. Don't worry. You can just answer the questions, whatever is there. Because it is a part of the whole exercise, which is mandatory from AICT as well as from our institution. So please complete the questionnaire. So once you're done with this, then we'll start with the next session. Who say? Start or? Start ಮಾಡೋಣ?
करेंगे. Once again, very good morning to one and all. Now we will start the first session. Now we have a speaker, Dr. M.S. Ganachari, sir. So, sir is going to discuss on historical perspectives in clinical research. I'm going to brief on sir's biodata very shortly. Sir is having rich experience in the academics and research. He has 30 years experience. Sir got Best Teacher Award 2010 by KL University, Belagavi. And Sir got Best Scientific Paper published in Indian Journal of Pharmacy Practice during 2011 by APTI. Sir is having almost 72 papers in international and national journals. Sir has delivered more than 100 guest lectures in various levels. And Sir has organized many workshops and conferences in various capacities. Sir has guided more than 66 M.Pharm dissertations. He has guided 7 PhD students. And Sir is our mentor, guide, and always gives us motivational messages. And Sir is having present status. He is a Deputy Registrar of KAHER, Belagavi, and Professor and Head of the Department of Pharmacy Practice, KLE's Dr. Prabhakar Kore Hospital and MRC, Belagavi. Sir is Member Secretary of KAHER Ethics Committee, Research Pharmacist at KLE University Research Unit in collaborations with NIH and Bill Gates Foundation, Global Network for Women's and Children's Health Research, and National Institute of Child Health and Human Department, USA. And he has served as clinical pharmacist for phase 3 clinical trials of Misoprostol, NIH, USA. And he is the member expert committee PharmD course constituted by Pharmacy Council of India, New Delhi. And I would like to tell, Sir is one of the co-author of the one of the journal that is Lancet. It's a high impact factor, 59.1, and many publications are having very high impact factors. So with this brief, I welcome you, sir, and sir is going to hand over the session. Thank you.
Thank you, Dr. Shashikala Wali, and good morning, all the participants. Once again, it is a privilege for me to be the part of this QIP program. I've been asked to talk about historical perspectives of clinical research. As you all know that this entire session is this 1 week program we are called in the trends in clinical research and the development. As a part of this, we can start with a brief history, then what is the current scenario and what is the future of this clinical research or clinical trials. Always it is nice to look back into the history, saying that what made us to reach here and what are the roads ahead. With this, I think my slide is visible to everyone. As long as we look for a history or we look back into the historical landmarks, many times we get a very informational materials, encouraging stories is some of the things which will be cautioning for us and so on and so forth. Today I'm going to talk a little more history, way beyond, much beyond the 1947 and till date, what has happened to the clinical research or the clinical trials and what are the ethical challenges for the conduct of these studies. If you quickly go and summarize the whole story from 1947, much earlier to 1947, somewhere between 1932 to 1947, a lot of changes were there in the clinical trials, approach in the clinical trials, thrust for developing the new drug, challenges to identify the new diseases, and so on and so forth. Subsequently, huge amount of things were transformed from 1947 subsequently till the today's date. We look for that, what is the 20th century research ethics milestones, step by step, one by one. Friends, as you know that it is a quality improvement program. I trust all the students, the senior students and teachers have joined. Let us make it more interactive. Should you have any questions, please ask me, add it and let us make it more interactive sessions. We know that unfortunately the whole world as of today also we're undergoing some threats of the war. A lot of things are happening in day and date today in the news and all those things. We're hearing a lot about the war that has been going on between the Ukraine and Russia. However, we'll not talk about those things. But if you look for the historical perspectives from Germany, the Nazis from Germany in the just beginning of the World War II. This was the era where the people were talking about where they were most scientifically and technologically advanced country in the world. Germans are known for that. They are very much highly advanced people technologically. That is the reason many of the industries, automotive industries are all come from this, the part of this world that is from the Germany. Where in this Germany people or Nazis in Germany had to propose a code of research ethics, which were aptly supported by the midwifery, nutrition programs, ecology, public health, human genetics, cancer, radiation, and the asbestos research. This was way back in just beginning of the World War II. But subsequently, the Nazis also exploited the people's trust in the medical community by performing a lot of unethical experiments on population that discriminated against. Either it is a downtrodden populations, population of special interest, prisoners of war, and so on and so forth. The both sides of the coin we can see in the history. If you look back into the history of this, the Nazis or the Germans or anything else, we have got a good thing because it started development of the questioning where there, why the disease is happening, why the diseases are coming, how to treat the diseases and so on and so forth. But other side of the coin was that, other face of the coin was there. It was placed on record. A lot of exploitation was there to address the hypothesis or the questions which raised amongst the people, amongst the scientific community or the fraternities. Subsequently, there are a long list of experiments that were conducted, or a long list of the experiments in medicines were conducted. That's battlefield medicine experiments, right from 1942 to 44, and it continues. I'll explain a little more about these things. In 1942, they started understanding high altitude or low pressure experiments in the part of the Germany. The medicine people or the medical people were to understand the soldiers, the warriors. What happens when they go and work in the very high altitude, or particularly when they work under low pressure, what happens to their physiology, what happens to their psychology, what happens to their energy, and so on and so forth. Subsequently, 1942 to 43, they wanted to understand what happens to the people, how long they can withstand the temperature, the freezing experiments. How long, to what extent the person can withstand, whether it is a 0 or sub-zero or up to minus. The people, they used to expose the people to the temperature without any protection or without anything, warmers or anything else. Just they have to keep on the ice for days together, hours together, and try to understand what is happening to the physiology of the person, what is happening to the mental stress of the people, and all those things. And in 1942 to 45, greatest the experiment they did, it was on the malaria. And in 1943 to 47, phosphorus burns experiments were being conducted. When the people will get burned in the war, when they get burned, or when they get burned due to the phosphorus and all those things, what happens to the wounds, how toxic is the wound, and all those things. Subsequently, in 1944, seawater experiments were done. So all these experiments are done with a lot of logical or the scientific temperament, but they never realized, or they just compromised their what we call as ethical challenges. The people who have been forced to stay at very high altitude, low pressure, freezing point, -5, 10, and all those things. What happens to the burn? Normal person used to give the shock of the phosphorus burn and try to understand that what is happening. Nobody realized that whether it is ethical or not, whether it is human or inhuman, and all those things. Subsequently, there's Ravensbrück. There's another thing which goes on the downline of the history. It is also called as a doctor's trial, where women were shot or slashed on the legs. They used to make a fresh wound, and the wounds were stuffed with the glass, dirt, bacteria, culture, and so on and so forth. Try to understand that how the wounds will get infected. And subsequently, they should treat with the anti-infective agents, which recently they've been developed. The anti-infective agents, they were trying to do those things because they wanted to understand if the soldier, if the military people get wounds, how they wanted to treat it. So they used to create in the women's or the prisoners of war a fresh wound. They used to create, infected by the various things, and then try to treat the people who have been infected by, deliberately infected by these things. So this is how the whole thing started, much before the 1947. Precisely between 1942 to 1944, these are the things were being conducted on the human beings. Then comes in 1947, apart from those things, that syphilis study was there, Nazis experiment, as I said, human radiation experiments. They wanted to understand what happens if people get radiations, exposed to the radiations. Now, whatever we are calling is a nuclear bomb. You might have heard about the Chernobyl. You might have heard about the Hiroshima and Nagasaki. These are all the things where they wanted to understand what happens to these things. When the people started understanding and thinking that what the people are doing is unethical, it is very rude, it is very inhuman, and then only there came the concept called as a Nuremberg Code in 1947. When the people start learning, they started coming out with the different guidelines and all those things, how to take the care of all those things. In 1947, the first time they call it as a Nuremberg Code. The whole idea of the Nuremberg Code was to have the voluntary informed consent. You can't enroll anybody else. The important three triads were their informed consent, right of subject to withdraw from the experiment at any time, and human subject cannot be sacrificed for the greater good of the science, and investigator must terminate the experiment at any time in the interest of the patients or subject without if they are in the threat or if they are at the risk. These are the 3 or 4 concepts they brought up into the what they call as a Nuremberg Code. Again, it is in a country, it is a city in Germany. They sat together and said that they wanted to do that. If you want to do any experiments, please, you are going to include these components. You should have to ask, are you interested or not? They should volunteer for those things. Then only can do the experiments. Even if they're the prisoners of war, you can't do it. A lot of human rights commissions, people all started talking, protesting, and then they came as a Nuremberg Code. This is the first milestones in the historical perspectives of the clinical research, clinical trials, and ethics in clinical trials. Subsequently, the human radiation experiments, as I said, it was done in US, which was done off late, not very old, in 1994, even that subsequently the President Clinton was appointed for the committee for Archer, that is an advisory committee on human radiation experiments, to investigate unethical experiment conducted by government, US federal government during World War II and in the what is called as a Cold War era. During that time, they used to have the human radiation experiments, and they tried to set up a committees to appoint whether it was ethical or unethical. Subsequently, this Archer's investigation revealed that they were been testing on the soldiers, feeding radioactive cereals to teenagers at the school for the mentally retarded, eradicating the testicles of prisons inmates, injecting plutonium into the hospital patients, intentionally release of radiations into the environment. So these are all the things they did it, presuming that they're doing good for the larger sciences, but that was not at all true, right? So this investigation revealed that they were all doing a lot of inhuman things, very highly unethical things, and so on and so forth. So subsequently, the around 4,000 human radiation experiments are conducted. In 2 programs, efforts by the US program, they provided, in the interest of, they call it as a provide a national security, provide medical studies to improve the health, human health. That was their assumption. But too oftenly, it was realized when the inquiry committee was set up by their own government, it was too deceptive. They did it secretly, many times with or without the informed consent. Many times it was without the consent rather than with the consent. It was highly deceptive, highly secret, and highly unethical. Then, after this, the progress of this, the understanding of the clinical research or the clinical trials still continues after this radiation and all those things. The biggest tragedy of that was the World War. There was unethical things. There's another part of the practice it came was the thalidomide tragedy. I would like to throw small light on this thalidomide tragedies. If the students of pharmacology department of reading the Satoskar book or even Goodman Gilman, somewhere they given the color picture of a boy with a sealed limbs. Phocomelia, what they call, where this thalidomide was approved by Europe in late 50s, but not in US due to the diligent efforts by one of the US doctor. However, it was a common practice among the pharmaceutical companies as some US doctors were supplied samples and paid studies for safety and efficacies. And we all know that thalidomide was prescribed for the morning sickness for a pregnant woman. To overcome the morning sickness, the thalidomide was prescribed. But nobody knew that thalidomide had got a serious adverse event, which is called a sealed limb. That's what we can see in the just a minute. Yeah, you can see the sealed limb, which is called, greatly it is called as the thalidomide disasters. Subsequently, it was discovered that the thalidomide causes severe deformities in the babies, and its effects were even passed on to the later generation, which was the worst ever identified that disaster of any of the drug. Then subsequently, it was much worse was that it was in passing on to the next generation. So we have seen the history of before the scientific people that things were been grown up much, during the World War or earlier of the World War, people want to understand, and subsequently even drugs were causing the serious adverse events where the people started thinking that nothing is safe. We should have to bring down the guidelines, rules, regulations, and all those things. This is how it from this 1947, little later was a thalidomide tragedy. And another thing in 1962, Coffers-Harris Amendment, Foods and Drugs Act and Cosmetic Act came into the picture of USA, where they looked at the practice of pharmaceutical companies, where they started advocating that required more testing before widespread use of the drugs. And they made it mandatory that informed consent form patient receiving the experimental drugs. Now we call it as an IMPs, investigational medicinal products, what we call. If you are going to use it, you are supposed to use the consent from the patients, whether it is a verbal, whether it is a oral, whether it is a video consenting, or whether it is a written consenting. Depending on the law of the land, you should have to take the consent. So this was signed as the act in Food, Drugs and Cosmetic Act, which is called as an 1962 Keffer-Harris Amendment Act. After this 1962, moving from thalidomide, the development of the Nuremberg Code, then subsequently, that is socio-behavioral studies were been brought into the pictures. This is very interesting. Just to recollect, as I said, a lot of torture was done, unethical duns were there on the prisoners of war. They started using the healthy volunteers. Then the drugs came in to become a culprit like thalidomide. And some set of people were doing the social behavior studies, socio-behavioral studies. It is called as a Milgram study of obediences to authorities. How to behave in front of the boss, how to behave in front of the superiors. They call as an obedience to authorities. They wanted to test the people, try the people, how they differently behave under the socio-behavioral studies. Here, subjects were coerced into the feeling they had a serious injured somebody else. They should create a scenarios and try to understand their behaviors. A very popular video is there. You can click and subsequently see the video that is called a Stanford Prison Experiment. And title says that what happens when you put the good people in the evil places. Catch hold of the good people who doesn't have any criminal background, who doesn't have any intention of the crime or anything else, put them into the prison. So what happened to their behavior? What happened to the socio-behavioral studies? This Stanford was where they conducted this experiment. If you look the video, you'll get a very heartening or a very the challenging video they posted on the website, saying that they created the prisons in the university. In the classroom, the guide or the preceptor or the head of the department asked the students what they want to become, whether they wanted to become the criminal or they wanted to become the guards. They separated, saying that the set of people who wanted to become the criminals, they put them in behind the bars in the universities, and they wanted to become the guard. They give all the baton or the gun, or they authorized them to behave like the warden of the prisons. Subsequently, they saw that there's a huge mental stress was there. How they withstand, how they react, which is totally unethical things were there. That is called as a socio-behavioral studies of the Stanford Prison Experiment. I'm sure you can enjoy that. Sorry, not to enjoy. You can go through that video link, what I've been showing here. It is called as the prisonxp.org. You can click, or you can put the Stanford Prison Experiment. You can certainly see that, and you can understand that how people are serious, was unethical to do those things. Subsequent, then later on as a radiation experiments on the soldiers to understand what fear people have got it. Do they fear, the people get fear, how fear they've been addressing, how to quantify the fear. So these are the experiments we have been classified as the socio-behavioral studies. Then after this 1962 and the Milgram studies, then it comes the people after, then again the people started thinking, saying that nothing was much developed in after Nuremberg Code of the consent and all those things. Then came the picture of Declaration of Helsinki in 1964. Here the research with humans should be based on the result from laboratory and animal experiments, not directly on the human beings. If you want to check the radiations on the human beings, you can't catch hold of the persons. If you want to test the anti-infective drugs, you do not catch hold of the people. First, you should have to demonstrate in the laboratory. Then subsequently, you can demonstrate on the animals, prove the results are appropriate. Then you can do we all know that I'll be hearing that whether it is a preclinical, clinical, phase 1, and so on and so forth. The research protocol should be reviewed by an independent committee prior to the initiation, just to avoid the bias. The third person, ethical people, should come, sit and see that whether the protocol is good. Just we can't test the protocol because I love to do that. Precisely, if you are seeing the very close to the war, what is happening between Russia and Ukraine, you can see that still are we there in the 1960s or in the pre-civilization eras or on, we don't know. We are trying to understand, saying that what is happening there. Similarly, in 1964, that is called Helsinki, the Declaration of Helsinki was been constituted. Again, it is a city over there. And then they emphasize, saying that informed consent from research participant is very much necessary. Research should conduct by the medically, scientifically qualified individuals, not a commander, not a commandant, right? Not a ruler, the ruler. They can't conduct the research. They should be medically, scientifically qualified, and risk should not exceed the benefits. Other pharmacy practice people or clinical pharmacy or pharmacology people, we do appreciate, I trust that risk-benefit analysis is very important in the clinical research or the clinical trial. That came into the picture in Declaration of Helsinki in 1964. They emphasized that, yes, very much consent is required. Research should be conducted by medically, scientifically, not only qualified, you should be trained, right? Because just I'm an MPharm PhD, if I don't have the procedure, I don't have a proper training, then I can't conduct. Not only qualification, even training was made mandatory in 1964. And the researcher or the person who is the principal investigator had to demonstrate what is a risk-benefit analysis by conducting the trial. That was conducted in the part of the Declaration of Helsinki in 1964. After this, interestingly, in 1966, that is called Beecher began his famous articles in New England Journal of Medicine, where he stated saying that medicine is sound and most progress is soundly attended. How to interpret this sentence which was written? I repeat it once again. Medicine is sound and most progress is soundly attended. So it was published in New England Journal. What does it mean? He went on to describe, saying that 22 examples of research studies with controversial ethics conducted by the reputable researchers and published in the major journals. He said that medicine is good, it makes a lot of sound, but the progress was soundly attended by publishing the journals. As a teacher, we know that the challenge of publications. On lighter side, many times the administrators say that either you publish or perish. Along with the publication, patent and flourish. However, it was observed that a lot of people started publication with where it doesn't have any scientific content into those things, with a lot of controversial ethics and all those things. It was made a big news in New England Journal of Medicine, which is to be a very high impact factor and the very important journal. So until these articles, we assumed that unethical research could only occur in the deprived regime like the Nazis. As I said, not necessarily Nazis and prisoners of war, or whether it is Germany or Russia, it's not necessary. Even the qualified people were been part of these unethical practices. This is how the concept was been taken from the Nuremberg Code to the Declaration of Helsinki and all those things. In every sector that unethical practice was happening. Earlier World War II, as I said, we give a lot of examples of the low pressure, low temperature, high altitude, radiations, creating a new wound and getting infected, so on and so forth. Equally, the people are very curious in the world during 1950s and 60s to understand the medical sciences. Set of people started working on socio-economical or social behaviors. As I said, the Stanford prisons, they put all the good normal students in the prison, tortured them and tried to understand what happens to their behaviors. Parallelly, after 1964 onwards, in New England Journal, it came to the picture saying that even well-known doctors, scientists were into the unethical practices. So this, from 1947 to 1964, nearly the 2 decades, then came in 1972 the syphilis, the AIDS. Really, it is very, very heartening or very terrible things to read as the history goes down. Here, the syphilis, the untreated, it can lead to, if there have been no patients, if they have been not treated, it leads to the severe heart diseases, brain damages, paralysis, and death. But the problem was until 1907, no one could treat the syphilis. We know syphilis is a sexually transmitted disease. We know that it is a sexually transmitted disease. Ramesh, I can do it, no problem. So this Till 1907, nobody knew how to treat the disease. Then people started working on that. The people started doing the research. So what was the research they did? The people who have been infected, or they brought the healthy people to treat the infected with the syphilis, and they were trying to observe. Even then penicillin was available in the market, they never treated, they got deprived of the drugs, and they conducted try to understand the growth, prognosis of the syphilis diseases, and try to understand how to treat the diseases. Of course, later on, in the Nobel Prize winning microbiologist Paul Ehrlich will discover the Cefalexin, which is an arsenic-based compound. It was the first chemotherapeutic agents which they've been came into the market. Subsequently, 1920s, there is a huge progressive era in the medical medicines, where they brought the armed the confidence of the scientific method. People worked with the public health service officials were determined to control syphilis in that time. They started setting up the free treatment clinics throughout the South, including the McHenry County, Alabama, home to the Tuskegee Institute. People who love to understand the history, you can Google what is Tuskegee Institute. What is the role of Tuskegee? It's a very interesting story. If you love it, please, you can visit it and understand. You can go for Wikipedia. A lot of videos are there. Try to understand what is a Tuskegee the case. But in 1932, the funding for treatment ran out. There was no funding while writing the final report of the syphilis, where the Taliaferro Clark, head of the PHS Venereal Disease Division, conceived an idea of the salvaging the studies, where the study was conducted in McHenry County, offered an unparalleled opportunity for the studies of the effect of untreated syphilis in Negro males. Why he did? Dr. Clark, because he was not having funding to treat, and which was funding for treatment ran out. He wanted to understand the whole the progression of the studies. The study of the untreated syphilis in Negro male in 1932 to 1972. Can you imagine, for more than 30 years or 40 years as the study went on, where it was supposed to was only supposed to for the last year, but subsequently Dr. Raymond advocated continuing the study to get the autopsies of the people after dying through the infection of the syphilis. That's the reason they monitor the people without treating syphilis for nearly the 40 year long in a Negro males, because they wanted to do the autopsy when the person dies with the infection. What happens to the lung? What happens to his kidneys, and so on and so forth. But autopsies would confirm the clinical observation and therefore greatly contribute to the scientific reliability of the study findings. That was their assumptions, and they enrolled a person from 1932 to 1972. After bringing them to autopsy, by the time the Jane Helker broke the story in the Washington Star, these publications or the newspaper Washington Star in 1972, the experiment had gone on for 40 years. Can you imagine? 40 long years. And interestingly, during all this time, it was not a secret to the wider medical community. The results of studies had been published in a well-known medical journal, yet no one ever questioned the study's approach. All were focusing only on the outcome of syphilis disease, but nobody understood or nobody questioned the ethical or the integrity of the study, what they've been conducted. Around 399 patients or participants were enrolled, but the darker side of the research where no one were ever told they had a syphilis. They hidden it, deceptive. They never told that you had a syphilis, and they went on monitoring their prognosis of the disease till they die. After death, they took over to the autopsy of the people. None were ever offered a cure. Highly unethical, because by the time penicillin became available in 1943, which was used for many of the infections. Penicillin was supposed to be an anti-infective as a wonder drug for many of the infections. But all the researchers kept it confidential, or they never given the opportunity to treat the patient, because they're more interested to see the prognosis of syphilis till the people, all 399 patient dies. do the autopsy and try to throw the light on medical sciences. But it was highly unethical. And even the researcher had even interfered to keep subject from getting penicillin. They avoided the people to get penicillin, and because the study could have been continued. So directly mentioning the patients, all 399 patients, even if they're interested, they have been deprived of getting the treatment for the patients suffering from syphilis. So nothing learned will prevent, find or cure a single case. So what was the outcome? 28 men died of syphilis. Terrible, disturbing. 100 men died from related complications. Still worse is at least 40 waves were infected, cross-infected. As we know, it is a sexually transmitted diseases. Out of 399 or little more than 399, 20 men died with syphilis, 100 men died with related complications. 40 wives were infected. Still down the line, worst thing, 19 children had contracted the disease at the birth. And whole people trust was shattered on the science, on the medical fraternity, on the research, and so on and so forth. The syphilis studies, if you read it, it is very, very worst, which I have read it across the historical prospect of the research. Imagine people getting infected, having the treatment is available, but still they don't want to treat the patients. And the outcome was that 28 people died, 100 infected, 40 wives were infected, 19 children were also infected. By doing this, the whole science fraternity lost their trust. What they called it as a bad blood. In the layman languages, the syphilis was called as a bad blood. And how this all thing went into the picture, or how it went on, is that the Mechanic County, as I said, residents were very poor. They were all belonging to the labor class and all those things. They lived and died without any medical care because they could not afford it. And they failed to distinguish between the syphilis and a host of other maladies, which they called as a bad blood. They think they had got a bad blood. That is the reason they're studying with the syphilis. If you recollect the pathophysiology, you know what are the signs and symptoms and the entire pathological the progression of syphilis. The poor people of Mechanic counties were deprived, and they called, no problem, you have got a bad blood, just go to the doctor, they will treat you. And unfortunately, they trusted the government doctors and they traveled the great lengths to get a little free medical care. Just they were told that they were being treated for bad blood, but they never told that you have been got infection of the syphilis. They never educated them, counseled them about the precaution, what they're supposed to take it. Treatment was available, they never treated because their goal was to do the research. Then after Belmont, the Declaration of Helsinki, after the Nuremberg Code, the final report of Tuskegee syphilis studies came into picture. Subsequent progressive government set up committees to understand this Tuskegee syphilis studies, why conducted, who conducted, what they did, what was unethical practice, and so on and so forth. The final report was tabled. And the report says that society can no longer afford to leave the balancing of individual rights against scientific progress to the scientific community. That was a report of Tuskegee syphilis claimed that you can't take the people for a ride just because you want to do scientific progression for a scientific community. No. Then after Tuskegee syphilis, the trial or studies were there, then they made into compulsory that it becomes an offense in any of the countries is if you do the trial or the studies is without proper consent, without proper animal studies is, without proper preclinical studies is, it becomes a criminal offense. Then the people try to educate all the people. No, you can't do those things. After such a horrifying story experiences, the stories of all those things. So this was the story came from 1947, Nuremberg Code, Coffers-Harris Amendment in 1962, Declaration of Helsinki in 1964, and 1972 syphilis studies saying that what happened to those things. Of course, in 1966, As I said, that Beecher's article says that the NEGM, the New England Journal, published that even the lot of fraudulent data were published in many of the national, very international journals. Later on in 1974, at Belmont, a National Commission for Protection of Human Subjects began deliberations. The picture shows that it is in a Belmont. It is one of the department in the university in the Belmont, where they constituted committees, a long list of committees. You can see that in my slide, where they set up a commission, giving the mandate to the commission to protect the human subjects, where they are going to end the research. The both things, we should have to do the research if you want to progress the science. We should have to do the research to understand the progression of the disease, whether it's infective, whether it's a lifestyle, whatever things are there. But how to balance by involving the human beings, what guidelines should be there, a set of long list of the right from Kenneth John to Robert Turtle, people who have been constituted a committee in the Belmont in 1974. A commission was constituted and they started deliberating on the challenges. And the National Commission for Protection of Human Subjects met monthly for 5 years. Can you imagine? For 5 years, they went on meeting from 1974 to 1800 for the 5 year long in Belmont Mansion in Eldridge, Maryland, which was built in 1800s. So this was the story or the history about this, how the Belmont report came into the practice. With this Belmont report led in 1978 to the opening words of what they call as a Belmont report. What does it say? The Belmont report says that scientific research has produced a substantial social benefit, no doubt about it. Also, it has also posed some troubling ethical questions. They started with the hypothesis, this commission started with the hypothesis saying that yes, scientific research has produced a substantial social benefit, whether it is at diagnosing the disease, understanding the symptoms, treating the diseases, developing the new drug, developing the new methodology, surgery, it is good. But there was underlying ethical challenges were there. This Belmont report highlights is that how to strike the balance between the research and the unethical practices. And there's a 3 basic ethical principles of Belmont report came into the picture: respect for person, beneficiaries, and the justice. These are 3 triads go hand in hand to understand or the basic strong, the foundation of the ethical principles which came out in the Belmont report in somewhere in 1800s. I'm sure you have got the details. I'll not go into detail. What do you mean by respect for a person? Just to summarize, respect for the person, you should have to have the informed consent. The person can enroll without any question. Equally, he can exit from the research without any questions. That is a respect for a person. Beneficiary was that they should have to strike the balance between the risk-benefit analysis, and you should have the justice. Why are we doing this research? Just because I love it? No, you can't do it. Just because I'm passionate about it? No, you can't do it. Until you justify scientifically why the research should be done. So when you complete the cycle of respect for the person, basic benefit for the patient who are participating, benefit for the larger communities, and subsequently the justice will be done for the research hypothesis. That is called the 3 basic principles of Belmont report. Respect for person, already said it, you should be having a voluntary informed consent, and individual is to be treated as an autonomous agents. Autonomous means they should have a lot of 100% autonomy. And the person with the diminished autonomies are entitled for protections. We call it as special populations, or they call it as vulnerable populations. In some of the communities, we call it a special population in the country, but globally they call it as vulnerable populations, where they call the diminished autonomy. Who has got diminished autonomy? Obviously, prisoners of war, employees of an employer, the students of an institution, old age home, right? All these people are being considered as a diminished autonomy. They don't have autonomy. So the people have started framing the rules, what they call as respect for a person. And the word informed consent was aptly tagged to call as a volunteer. Voluntary means what? On his own, willingly is going to join, not by coercion, not by paying the money, or not by the compulsion. That is a respect for a person. The benefit is that when you do the research, the first thing, do no harm. Even if it's not going to benefit, but don't do the harm. That is the whole possible. Of course, you can maximize possible benefits and minimize the possible harms. But the motto was that in the beneficiaries, there should not be any activity should not harm. And the application was assessment of risk and benefit. As I said, it is called as a risk-benefit analysis. For any study, the people has to put on the risk-benefit analysis, and then a research hypothesis should have to support the confident or the component of risk-benefit analysis for approval of the study. The justice, as I said, that who ought to receive the benefit of the research and who ought to bear its burdens. That is called the justice. And application was equitable selection of the subjects. As I said, the poor, down-to-earth people, orphan age homes, orphan people, the old age people, old age home people, socio-economically deprived people, prisoners of war, students, employees. So all they've been called as either they're called as a vulnerable population or they're called as special populations. You should have to justice by equitable selection of the subjects. So after this Belmont report 1979, the understood start on continuing what was a home free in 21st century. But still risk is still risky. The research is still risky. A lot of gene therapy trials were being came into the picture where death of 18-year-old Jesse in 1999 had a lot of conflict of interest. As we all know that 21st century people started talking about gene therapy, cloning, nanotechnology, internet research, artificial intelligence, chemical and biological terrorism, space travel, and all those things. But research was still risky. So whatever the Belmont report and all those things could not be sufficient to address the new 21st century challenges. Hence, the world is not free from research is still risky for such type of the new upcoming of all the science that is been progressing, whether it is a cloning, nanotechnology, internet research, artificial intelligence, no privacy, chemical and biological terrorism. We are hearing the new words because of this terror, the war that is happening currently in the world. And of course, the space travel. We know that traveling to the space has become so common. People traveling from Belgium to Canada or anything else, the wealthy people can travel to moon and come back. At the end, after understanding the whole progression from 1947, 1962, 1964, 1979, 1988, 81, 1991, where they framed the common rules after understanding the thalidomide, Tuskegee, Milgram, Nazis, and all those things. If you see the photos of these Nazis, they're really disturbing. You Google it out, you'll get photos where the people were literally stacked in like in the cupboards. They were put in the ice, freezing, 0 degree, -0 degree, and all those things. This is an interesting or a quite befitting historical perspectives if the people want to make the career in understanding the clinical trials or the clinical research. So, what are the questions to be considered? Why should be concerned about the human subject research? Do you think another Tuskegee could happen in future? Do you think Tuskegee could ever happen to you? Can you imagine, put your foot in the shoes of the participants? What could have happened? The person is getting infected with the syphilis, which knowing it is a very deadly disease, highly infective diseases, highly communicable diseases. What happens should it happen to the individuals? Can you envision yourself ever being faced with the ethical dilemma in human subject research? What are some guidelines or resources that could turn down? And finally, the Tuskegee study started in United States in 1932 and continued for 40 years, well past the Nuremberg trials. It was also known, well-kept secret research articles were published in major medical journals during this time. Why did you think nobody saw the connection between the Nuremberg Code and Tuskegee syphilis study? This was a question was raised. And if you look for the then President 1997, President Bill Clinton, right? The President Bill Clinton asking apology in the Senate, in the parliament for the Tuskegee participant. And the right side, you can see the saw. He's one of the victim who is a Negro who has been tried for the syphilis studies. You can have the audio clip of this gentleman, and apologies been done by the then President Clinton in the House of US House, saying that yes, what research has been done was unethical and all those things. So just to conclude of the historical perspective, so life is all about choices, and choice have some consequences. So now it is turned, how will you choose whether you want to be the part of the trial or no? If yes, what precautions should be taken? What ethical perspectives are there? What is the law of the land? You should have to understand as a researcher, and as a part of the clinical trials or clinical research, you should have to appreciate and understand the consequences of all those things. Then only you will be taking carry forward if you are part of the trial. What every individual should understand, what precautions should be taken, what is ethical and what is unethical. Should you have any questions, I'm happy to take the questions. If you want to put the questions on the chat box, or else you can raise your hand so that you will unmute yourself to understand the questions. As I said in the beginning, all the participants who have been joined, mind you, you are all teachers, you're bound to ask the questions, and nevertheless, let us make it more interactive rather than making it more only didactic lectures. Thank you for patience listening for this particular talk on historical perspectives of clinical trials and clinical research. Open for discussion. Or else you can raise your hand so that you can unmute yourself, or else you can try unmuting yourself, or else you can put a questions in the chat box so that I can take a question and try to answer your queries. I think as per our SOPs, I think all the participants should have to switch on their videos. I request everyone to switch on the videos so that we can take a virtual attendance and screenshots. Yeah, nice. I can see a lot of videos coming on. Yes, anybody has got any questions or any doubts or anything else you want to add?
Excuse me, sir.
Yes, ma'am.
Good morning, sir.
Good morning.
It was very nice session, sir. But one thing I have just query with you, sir.
Yes.
As mentioned in was that as this QIP program through the WhatsApp that you have to download Zoom version 5.8.3. Then
Yes.
only you are able to do the quiz, because it is not happening with us. It's a very big problem for us. How it is possible? हमारा download नहीं हो रहा, sir. That's a very big issue. So if it is possible, can you give us a link so that we can fill the form within the stipulated time period?
we'll try to explore it because more than 40 people or 50 people already they have put their the poll or the quiz they attended. Probably there may be challenges with your the version what you have been using, ma'am. But we'll try to explore that. Is it possible to give a separate link for you?
Sir, I'm using 5.9.1, but thing is there, it is not downloading in my laptop. I am attending from mobile also with laptop also. And I have attended from morning 9:25. I've joined the meeting, Zoom meeting, but I am not able to do that questions. And again, it is a mandatory for all those questions. So please, sir, we want that it should be in some manner so that we can solve it.
Okay, we'll try to explore it and try to get back to you, ma'am.
Okay, sir. Thank you, sir.
By the way, you're from which college or which place?
Sir, I am from GLA University, Mathura.
Oh, nice. Right. Yeah. Other than that, any questions? Okay, we know that as we all said that we are all the teachers and I'm also teacher. If you don't have questions, then I can ask some questions. Is that okay? It is yes or no. Okay, anyway, this is the other side of the virtual sessions, what we are conducting and all those things. I presume that I can see some in chat box. Are there any questions or? Nothing? No questions. Okay. Anyway, instead of wasting time and thanks for patience listening. And as we have been scheduled, there one more talk is there like of the Dr. Roy is a scientist G. Unfortunately, sir was not able to make up because we couldn't inform him well in advance. Our apology for that. But however, quickly I'll from 11:45. Time. Another specialty is there. We are trying to keep up the time. For another 15-20 minutes, I'll engage the sessions of ICMR guidelines for ethics committees review of the clinical trials during the COVID-19. Okay. I ask Dr. Ramesh to still I'm the host. Okay. I'll share my screen for the next session. What we are just give some minute and so basically this ICMR came up with the guidelines is because of the pandemic where ethics committees were not able to meet and review the guidelines. As we all know that just a minute. Can you see my screen? No, I think. Yes. Fine. So once, as you all know, that little more than 2 years is we are all undergoing the reeling into the pandemics. And as per the clinical research is concerned, we should have to continue this ongoing clinical trials. And a lot of clinical trials started popping in about the vaccines, for the COVID vaccine and all those things. They wanted to do the research. As we have seen, historically, we have seen saying that without ethical reviews, you can't conduct the research. But all our hospitals and everything was closed. During that time, the challenge for ethics committee, because I'm one of the member or the member secretary for ethics committee, we started facing a lot of challenges, particularly the patients who are undergoing that part of the clinical trial. And a lot of patients is where they wanted to get a lot of research studies. They wanted to initiate the studies to understand the science behind the COVID-19, the infection, vaccines, control, regimens, the fixed dose combinations, and so on and so forth. During that time, ICMR came up with a lot of guidelines how the ethics review should be conducted during COVID-19 pandemic. So I'll not go into the details. As you all know that ethics committee review will be done as per the ICMR guidelines or the NDCT guidelines 2019. In 2019, new drug clinical trial guidelines came, where they say that ethics committee should have to be registered with the DCGI or CDSCO. We should have equal number of the members. I'll not go into the composition of ethics committee. I'll go and talk about the ethics committee. That is an ethics committee, ethics review for biomedical and health research during COVID-19 pandemic. The SOPs were derived and the SOPs were expected to implemented. And the purpose of SOP was to describe how the ethics committee will function and conduct the ethics reviews in an emergency situation with restrictions as imposed by the social distancing requirement during COVID-19 outbreak. So all this time, conventionally, we should get a research protocol. We should review them. 12 to 13 people, we should sit in the room. We should have to review the protocol and all those things. Because of COVID-19, they came up with the state guidelines of how to do these things. And of course, we do have also our own SOP. We amended our SOPs into different things. So one of the component of the review was that submission of the initial reviews. The researcher, the industries or clinical research trial protocol should have to be started accepting that research protocol electronically. It was the responsibility of the researcher. They can submit the research proposals electronically. Again, when it is said it is not mandatory, but it is an optional saying that if you couldn't submit the physical copies of the research protocol or the dossiers, you can submit it. That was amendment was done by ICMR as per the NDCT rules were there. Subsequently, to receive, record, verify completeness and allot of the reference numbers was the job of a secretariat or the member secretary. Once you receive it electronically or hard copies, but during pandemic, electronically was been acceptable. So once you receive that by the member secretary, you are supposed to acknowledge that receipt of the research protocol electronically. Then job of a member secretary in consultation with the chairman of the ethics committee was to categorize depending upon the risk, whether it should be exempted, expedited, whether it requires the full committees. Once it is determined, identify the need for the review by the experts or independent consultants, patients, and other designated reviewers. The member secretary is to categorize the protocol what has been received. And particularly the challenge was there when the Covishield vaccine trial came to our hospital. It was a big challenge as to whether it is ethically correct or not, because we not had a sufficient the data on the vaccines that is coming into the market. Government was pressurizing, industries were pressurizing, but we are not able to meet physically the challenge we are mounting day by day during the pandemic until as we received these guidelines. So once it is categorized into this, whether it should be expedited, exempted, whether it requires a full committee, and so on and so forth. Subsequently, to perform the initial review of the document as described in the table 4.3 of ICMR, National Ethical Guidelines, the field study evaluation form, what they call as the primary or the secondary reviewers when identified, the study evaluation form, the scientific review committee was been full board. Then subsequently Subsequently, the schedule of the virtual meeting where the amendment of the NDCT guidelines is or during the pandemic, the virtual meetings could be scheduled. We can prepare agenda, invite members, whether it's independent, consultant, subject expert, principal investigator, of the member secretary of the local IECs in consultation with the chairperson. So the virtual ethics committee members were permitted to conduct the meeting virtually. We did it in our the hospital in our college was that we conducted the virtual meeting during the pandemic as per this SOP of ICMR, including the principal investigator online. He presented, all members were listening online. We had interactions, and then we voted for the approval or not approval of the protocol. This was the first amendment was been the first section of the amendment of submission of the and the initial review of the protocol. Then later on, they gave the detailed guidelines of the virtual EC meetings. How EC meetings should be conducted virtually in keeping in the mind of all the rules, regulations, sanctity, the confidentiality, and all those things. So the open the meeting, determine the quorum as per section 4.8.4 of the National Ethics Guidelines, saying that the chairman should have to do the opening and determine the quorum. Whether the quorum
Sir, can't able to hear you. Excuse me, sir. Sir, excuse me, sir. Excuse me, sir. It's unable to hear your voice, sir. Excuse me, sir. Sir, could you please unmute your mic? We are not able to hear you. Audio is not coming, sir. Please check the settings. Till now, no audio has been given to us.
Can anyone unmute or put a chat?
Yes, sir. Now I can hear it. It got disconnected again. No, I cannot hear it, sir.
Yes, so now it's okay, sir.
Is working?
Yes, sir.
Yes,
Now
sir.
it's working.
Okay. I think from 11:53 there, just summarizing the guidelines of the COVID-19 pandemic. And currently, what we are doing is that we are conducting the hybrid mode, using both the online as well as the offline. We are encouraging the people to come online, physically, but some people are joining online. Probably in upcoming meetings, we are going to conduct all our ethics committee meetings physically. But just to share a couple of things during pandemic, really it was a disaster for us. We should have a lot of pressure to approve the study, but we are not able to move around, meet anything else. But these ICMR people were in April 2020, they came up with the guidelines. Then it helped us to issue the protocol and then start approving the protocol, whether it is a vaccine or ongoing oncology studies and all those things. So these are a summary of ICMR guidelines, and these are the amendments what they put into the on place, saying that how best we can do the review of the protocols during the pandemics, right? Anybody has, by this, I think I'll be summarizing and completing my talk about the guidelines of ICMR during the pandemic. I'm not going to go into the details of all those things, assuming that we know all those things, just to highlight the guidelines during the pandemic, right? It is open for discussions. Any questions or any doubts, you can put it on the chat box about the ethics committee review or even my earlier talk. Yes, no questions? Okay, Dr. Robin George, you're from which college? Can you unmute yourself? Dr. Robin, you are around there? No? Yes. Yash, you want to take, Yash, after you want to say something? Okay. Anyway, there is no questions or anything else. I thank all the I think one chat is there. I'll just check it out. Right. Regarding COVID-19 vaccine studies, what were the ethical issues, especially regarding the willingness to vaccinate? So what was your perception on this, sir? One of the participants is asking, so what was my perception or what was our perception regarding the COVID-19 vaccination studies? Well, it is a good question. It is quite an interesting question, saying that what was the willingness to people to get vaccinated? As you all know that in the initially, both the things were been found. I'm sure that when Covishield vaccine was announced, the first time, one of the center was in Belagavi. One of the first center was in Belgaum, saying that the trial used to be started. We heard both the things. Some set of people are quite cautious, quite enthusiastic, saying that they wanted to be the part of the vaccine trial because one thing, they wanted to get protection. Second, they wanted to get the vaccination at the earliest. As usual, another population was there. They're very skeptical. They wanted to understand before they wanted to take the call, saying that whether I want to become the part of the clinical trial or not. We had a mixed experiences initially in the month of in the year of mid of 2020 or the beginning of 2021. But subsequently, yes, the people were trying to understand. They started volunteering to become the part of the vaccines, and all our studies have got a good enrollment for the vaccines, whether it is a Covishield or whatever the trials of the vaccines were there, they came into the picture. But initially, yes, both enthusiastic participants were there, non-enthusiastic were there. Even highly enthusiastic patients are not good in the research because just they want to get protection without understanding. We are able to handle the situations by both the ways during the COVID-19. Hope I answered your question. You click that square box, mag top. Yes. All right. Any other questions from anybody else? Yes, I can see one more. Right, nothing has acknowledged my this one. Yeah, fine. Just a piece of word for all the 69 plus participants who have joined. As I said, we should be more interactive, more proactive. Ask some question. If you don't have questions, at least you can share your experiences. So that is the difference between the workshops and quality improvement programs. Otherwise, there's no meaning for this type of the sessions what we are conducting. Of course, this is a challenge for conducting the virtual programs. AICT has not permitted us to conduct the physical programs. That is the reason we're conducting these virtual programs. I thank all the participants being so serious, being all the way from since morning, being the part of the inaugural program and all those things. If no questions or anything else, I think we'll break the session for a lunch, right? And thank for all the participants. And the session will be at 3 o'clock. The new drugs, the trials is in the as per the rules are there in the clinical trials. Mr. Tarang Shah is a senior medical writer. He has changed the topic. He's not going to talk on that. He's going to talk about the science, medical writing. He is going to talk about the submission of the scientific study reports to the government and the agencies. He's a senior medical writer of IQA Mumbai. He has consented. He'll be joining the session at 3 o'clock. I request all the participants to join 15 minutes earlier, 2:45. Please, you can join. And now we are closing the session for the day for lunch. And after lunch, we are going to meet it for the session. Thank you. Thank you, one and all. I think all can leave the meeting for the day, and please join at 2:45. Or Hello, good afternoon, ma'am. Yeah.